Hello everyone, welcome to the lecture on community media and health. This lecture is part of your paper on community media and society. In this lecture, we will try to understand health is a state of physical, mental, and social well-being as defined by the World Health Organization WHO in 1948. This lecture explains the relevance of social capital for health promotion. It also critically looks at the initiatives of the community mobilization towards building a healthy society and the challenges within the development sector to harness the potential of community media for this purpose. Through this lecture, you will learn the relevance of community media in health promotion. You will also develop an understanding of various approaches to community mobilization to promote better health and how community media can be used for maintaining a better health. Let's now begin with social capital and health. As you know, disease is a biological embodiment of deprivation. When one understands illness as a manifestation of inequity in terms of access to clean environment, food, education, and health facilities, and other socioeconomic determinants of health, one actually understands the linkage between health, culture, and power. It is the complex interplay of structural, social, political, and economic factors that have gradually shifted the focus of health communication theorists towards cultural and structural context of communication about health. Given the failure of sophisticated medical interventions and media campaigns against public health concerns, like, for instance, smoking, use of seat belts, teenage pregnancy, HIV, and so on, to yield the anticipated behavioral results, the shift towards social capital approach was gradual for the public health sector. While the mainstream approach focused on linear transmission of messages to the community, the shift to include community and understand the social context has led to adoption of the social capital approach. This social capital approach has been introduced to the public health field primarily by work of two individuals, Robert Putnam, whose seminal 1993 book on regional government in Italy, Making Democracy Work, and Richard Wilkinson, whose 1996 book, Unhealthy Societies, first introduced Putnam's notion of social capital to the public health field. Social capital, in simple terms, is a way to define the intangible resources of the community on which the daily life is drawn. These include social shared community values and trust. Putnam defines social capital in terms of a number of characteristics. These include the existence of community networks, which together constitute the civic community, involving institutions, associated facilities, and relationships in the voluntary, state, and personal spheres, and the density of the networking between these three spheres. 2. Civic engagement, like participation in the process of sustaining or using such voluntary state and interpersonal networks. 3. Civic identity, referring to people's sense of belonging to the civic community, together with a sense of solidarity and equality with other community members. And finally, norms gathering the functioning of networks, in particular norms of cooperation, reciprocality, obligation to help others, confidence that others will help oneself, and trust as opposed to fear of others in the community. While Putnam's original work on social capital was rooted in the disciplines of economics and politics, increasingly scholars have argued that it can hugely inform the public health sector too. Rather than reinventing the wheel, the knowledge accumulated from sociology, cultural studies, psychosociology, etc. can hugely benefit the public health system or public health stream. Elucidating the role of social capital in health, Gillis et al. 1996 underlined how poverty facilitates HIV/AIDS transmission catalyzed by factors such as homelessness, limited educational opportunities, the low status of women, and the disintegration of neighborhoods. He also explained that interplay of these factors results in destruction of the social cohesion of communities, that is social capital, increasing the vulnerability of community members to health problems. Thereby, to be able to strengthen health programs, it is imperative to strengthen community networks and address issues of power and structure. Now let's talk about community mobilization and health. The poorest people in the world are also often the ones with poorest health. As explained earlier by me, this is often due to poverty and the social inequities which prove detrimental to their health. Community engagement thus becomes a key to address social inequities and to determine the success of interventions designed to promote better health. Community mobilization usually involves collaboration among health workers and community activists or activities seeking to empower them or build their capacity to exercise greater agency over their well-being, increasing their opportunity for meaningful social participation and building enabling partnerships with supportive outsiders. Catherine Campbell explains that community mobilization can take various forms. Instrumental approach understands communities as agents of biomedical and behavioral experts. The primary role of the communities is restricted to help implement the programs conceptualized by the experts. This approach is top-down in nature, which means the message has been designed by experts and the community needs to implement it, and is often known as the dominant paradigm. Dialogical approach, on the other hand, promotes interaction between health workers and communities and facilitate dialogue between the lay and the expert understanding of health to design interventions which are closer to community needs. This is based on primarily Freirean principles of dialogue. Based on his work in communities battling poverty and government oppression, Paulo Freire's 1970 work highlighted the need for dialogue. Campbell explains it is through dialogue that the marginalized group develop critical understandings of social roots of their ill health, an enhanced awareness of their rights, and a sense of solidarity and collective agency that spurs collective action to challenge health-damaging social inequalities. In addition to these, culture-centered approach foregrounds the importance of listening to subaltern communities, that is, those communities which are located at the margins and are not represented by mainstream voices. The social capital approach calls for increased participation of the community and help them strengthen relations with the social ecosystem and build social networks in order to scaffold change geared towards improved health outcomes. Critical approach views community mobilization as collective action to challenge the power structures and tries to locate these efforts in the wide context of political and social context. This approach believes that in order to promote health equity, powerless must be able to demand their rights and the powerful must pay heed to it. Most of the community mobilization practitioners attempt to design their interventions within these four approaches. Though the instrumental approach is the most dominant practice, it is often critiqued of being disconnected from social realities and hence being extremely top-down. Practitioners are gradually realizing the importance of community participation and are gradually shifting their focus towards dialogical, culture-centered approach. Also, the focus has shifted towards building the social capital rather than designing the intervention in isolation. Given that no public health intervention can ever be a success without community participation, community becomes critical to ensure the success of the intervention. Borrowing their understanding of community mobilization from the theories mentioned about behavior change communication, BCC, behavior change communication, strategies have often focused on linear changes being promoted through the designed intervention. In India, grassroots organizations and different government departments, through various schemes, have been trying to promote better health-seeking practices. There are examples of standalone initiatives that have yielded exemplary results in increasing health-seeking behavior amongst the vulnerable, say for instance, polio and other immunization programs in this country. However, various researchers have identified critical gaps in current behavior change communication or BCC approaches. The current BCC techniques have failed to systematically engage communities and local stakeholders towards mapping actual risk factors. The interventions thus proposed towards behavior change fail to address social and structural barriers that affect behavior change. A threefold approach that integrates epidemiological evidences with social research towards building an integrated communication plan linked to monitoring and service is needed to scaffold behavior change. A participatory approach based on the principles of dialogue would aspire to involve local stakeholders from the outset in decision-making about topics, messages, program design and execution, and would bring together different types of groups: community, networks, media, ICT outlets, health and development experts, public policy representatives, all into collaborative program design, management and evaluation processes. Well, this makes the process of communication needs-based rather than a top-down. Given these, let's get into community media and public health interventions. The promise of community media for education and development is very significant, especially given the participatory nature of the medium and its proximity to social realities compared to mainstream media, for instance. Unlike mainstream media, it offers a scope for meaningful dialogue, which is closer to the community context and can thus easily motivate and mobilize people. Community media can therefore become an effective tool to promote community learning. Well, there have been many experiments done to mobilize the community using community media. Most of them have been limited to their understanding of participation. Let us try to understand this aspect of community media through an example. In a bid to harness this potential of the community media to its fullest, the Commonwealth of Learning (COL) initiated Community Learning Program (CLP) in 2007 across 9 Commonwealth countries, including India. The CLP is a combination of a dialogical and social capital approach to community mobilization. That is, its core principle is about promoting dialogue and critical thinking amongst the various stakeholders, and by providing links between these organizations to bridge the social capital of a community. CLP-based programs proposed to prioritize the lived experience and stories of learners and other community members, combining them with expert information. The CLP, the Community Learning Program, focused on hyper-local issues by taking certain measures. For instance, by involving local stakeholders from the outset in decision-making about topics, messages, and program design and execution. Second, by bringing together different types of groups, community networks, media, ICT, health and development experts, public policy representatives into collaborative program design, management, and evaluation. 3. Prioritizing the lived experiences and stories of learners and other community members, combining them with expert information. 4. By drawing on traditional cultural formats such as storytelling, drama, music, and other folk media. Also highlighting interactive, dynamic, and engaging formats, promoting multi-channel and blended approaches. For example, combining radio with mobile telephony and face-to-face interactions and community mobilization with engaging media content. Through various community media like community radio, WhatsApp groups, and also Facebook pages, the approach focused on building knowledgeable societies. The focus here was on education communication. That is, emphasis was given or was placed on the educational potential of community media. It is characteristic of community or modernity to view knowledge as hierarchical in nature and therefore place expert knowledge at a very high pedestal to be imparted to the ignorant masses. Such a viewpoint often doesn't recognize the indigenous knowledge system as legitimate. But CLP as an approach doesn't consider any one knowledge as superior. Instead, it creates a specific kind of public sphere in which varied legitimate knowledge systems can meet while giving equal footing to each other. Therefore, it provides a social space or public sphere in which an intermingling of lay and expert knowledge occurs. In the space created for dialogue and critical thinking, the two dominant knowledge systems of the layperson and expert knowledge meet and intermingle to form new forms of knowledge. These special spaces have opened up discussion on sensitive issues such as sexual health. Research in most marginalized communities point out that they do not have a platform that could perform the role of strong psychosocial scaffolding in which an exchange of ideas to serious problems can be discussed. A space for collective dialogue and critical thinking is a necessity for any behavior change to occur. A change is not targeted at an individual, but the interface between the individual and the society. Community media often has the potential to become that kind of a platform. It allows that the perspective of the other, within quote, the other, is taken into account and given its due recognition in this form of public sphere that is inherently dialogical by nature. It is in providing such a safe space that CLP succeeded the most probably. Let us now look at some voices from the field. Community radio producers shared many issues about sexual problems would never have been understood if we did not speak to the community members, as we ourselves never faced such problems and therefore had no experience to understand them. Therefore, talking to them helped us get a better idea of how to frame the script and episodes of the programs. We built a strong relationship with the community. We would not have gotten such powerful stories. This is Gurgaon Ki Awaaz, Gurugram. Through the radio program, these girls from urban slums of Bengaluru for the first time got a platform to speak about periods and difficulties. They don't discuss it even with their mothers and sisters. Many of them didn't know how many times pads need to be changed. So it was insightful for them and they got a good exposure. This is Radioactive Bangalore. In certain situations, when the social structures have failed to address the health concerns, primarily due to lack of communicative justice, communities' concerns have not been heard and addressed properly. Community media has emerged as a platform for amplification of community voices and has provided the safe space to share their concerns and join the health initiatives gradually. Let's now look at another example which elucidates one citizen's efforts to bring immunization to his village. In March 2017, all immunization and supplementation programs in District Nu were stalled due to false rumors about impotency tablets and fertility injections that led to panic in the schools. According to Times of India of March 9, barely any student were attending schools in the district. To address this, the district administration approached religious leaders to spread awareness about government's health program, such as the weekly iron and folic acid supplementary, WI, deworming devices, drives, and immunization programs for pulse polio, smallpox, malaise, diarrhea, and many more. A large portion of the population in Nu didn't understand the value or importance of immunization even before the rumors were spread. With only 27.3% children between ages 12 to 23 months fully immunized, DLHS 2013, the district had the highest infant mortality rate in Haryana. The above hemoglobin level among children was far below requisite levels. Surjit Sama, a resident of village Maulaka and the father of two, had always been concerned about the erratic immunization drives in his village and often raised his concerns to others in the community. He approached the village Anganwadi, the daycare shelter. The Anganwadi worker to no avail. He spoke to administrators at the general hospital, where he was told that the auxiliary nurse midwife A&M was unavailable. This further added to Sarjit's worry and about his children. Sarjit's mother, an avid listener of community radio, Alfaza Mewat, suggested that he share his concern over community radio. Skeptical but willing to do anything, Sarjit called the station and shared his concerns. Radio presenter Fakat Hussain found Sarjit's comments while reviewing listeners' responses and to action to coordinate with doctors at the general hospital for their participation in a live health program to discuss issues surrounding immunization. Sarjit participated in the live show via telephone and shared the immunization status in his village. The doctor on duty assured him of timely action to address his concerns. Soon after the live discussion, Sarjit received a call from the doctor seeking more details. A hospital team visited the village, and within the next 2 days, an extensive immunization drive was carried out. Sarjit was elated to witness these results, of course. When the community radio team congratulated Sarjit for his successful activism, he simply said, I quote, "Visits to the A&M Anganwadi worker and general hospital didn't yield any results, so I was very skeptical when my mother suggested I approach the radio station. Radio station staff took this up and helped establish a link between me and the hospital authorities. My concern reached the right ears and the right place." Unquote. However, community mobilization in the context of health has its own limitation and is often critiqued of conceptualizing social change as a linear process. Often the programs are time-bound and presume that social change needs to be triggered in the pre-specified time. The programs are designed often attempting to quantify the changes and measuring them in terms of measures adopted by people in the targeted community. For example, the linear understanding that increased messaging about sexually transmitted diseases will result in increased use of condom may fall flat, as behavior change or social change is not a linear process. Community media also often falls in this trap. Often for reasons of convenience, the programs target geographical communities, assuming that residents share common values and would have similar motivating factors. However, the realities are different, as communities' decisions related to health are a result of complex intersection of factors like education, caste, class, age, gender, and maybe quite a few others. Thereby, it is imperative to locate these programs within the community, along with buy-in from the key stakeholders, including community representatives, in order to ensure the interventions are sustainable and in sync with social realities. So friends, we have now come to the conclusion of the program. That is very quickly revise what we have learned in this lecture. In this lecture, you have understood the concept of health and social capital. By the end of this lecture, you would have understood that health is the result of complex interplay of structural, social, political, and economic factors, and thereby a mere clinical understanding of it removes it from the social realities. For any health intervention to be successful, it is thereby vital to have community participation, and they need to be engaged in the decision-making process. There are multiple ways to understand community mobilization. While the most dominant that we discussed approach is the instrumental approach, it is often critiqued of being very top-down in nature. We also saw that the dialogical and social capital approach have yielded successful results and have the capacity to be more closer to community needs and their realities. Community media, we also saw, has the potential to be a safe space for the communities and can motivate them towards healthy behavioral practices. There are multiple examples where community radio has proven useful to trigger conversations in the community level. However, these have their own limitations. So friends, this brings us to the end of the lecture. You are advised that you must read the model carefully for more details. Also, for further study, do go through the extended reading list that is provided within the lecture, and also attempt all the questions given at the end. Thank you very much indeed.